So this is my audience, and they're going to hear me talk about health readmissions. Alright, so I started this project 2 years ago when I first started in the bachelor program. And I decided to do it about hospital readmission rates because that's a big problem in many hospitals. Introduction, it's going to be about hospital readmission rates, literature review that I've researched, a PICO question, which I'll explain more later, theoretical framework, design, setting, and sample, and data collection and analysis. So, some information about my research proposal. Hospital readmission is defined as a patient admission into a hospital within 30 days after being discharged from an earlier hospital stay. 1 in 5, or 17.6% of Medicare patients experience readmission. Readmissions increase the risk of patient complications, and they also increase the risk of infections. Preventable reasons for readmission are deficits in care, medication errors, failure to plan for necessary equipment, and shortcomings in preparation of patients and family for care after discharge. Unavoidable reasons are like the 4 main chronic diseases, which are congestive heart failure, COPD, heart attack, and pneumonia. Hospital readmission reduction plan, or the HRP, was developed in 2012 as a policy type thing to try to prevent readmissions in the hospital. 2,213 hospitals were penalized, like a total of $280 million for high readmission rates, and readmission rate charges account for $15 billion per year in hospitals in the U.S. These are 5 studies that I researched. It's like studies that correlate with my research proposal. So study 1, Lepin, Griffino, and Kessler conducted a study in 2012 about preventing 30-day hospital readmission rates. They did randomized trials, activity-based coach strategies. All interventions that they tried were effective, and they were effective because of the statistical data of P equals 0.001, which is like a t-test if you're not up to date on statistics. Study 2, Wong, Chow, Chan, and Tam conducted a study in 2014 that compared the effects between home visits along with telephone calls and telephone calls alone for discharge follow-up care. They conducted the study using randomized trials. The groups that they used were a control, home, and call group. The sample consists of only chronically ill patients, so some of the results can be, like, they aren't global, like they can't be used for every situation, just chronically ill patients. The results determine that home visits are better than phone calls for preventing readmissions, and that statistical data is P equals 0.05. Study 3, Anderson completed a study in 2015 about the effect of follow-up phone calls on 30-day readmission rates for stroke patients. So those results can also be limited because it was only done on stroke patients. The groups that they used were a control and an intervention test, and they used Fisher's exact test for the results. They determined that follow-up phone calls done by a nurse are more effective in preventing readmissions than no transitional care at all. That statistical data is P equals 0.05. Study 5 was Hall, Expediso, Pikamarzi, Lesser, Marovic, John, Blinderman, Ankerman, Norin, and Hartman. All those scientists conducted a study in 2013 called Follow Your Heart. They did it to determine home visits after cardiac surgery. So they would have nurses go to the homes and visit the cardiac patients to see if that would prevent readmissions. The groups that they used were a control group and an intervention group. The results determined that home visits from nurses are effective in reducing readmissions and death in post-CABG patients. And that statistical data is 0.015. The 5th fifth and last study that I researched was Harrison, Arbach, Quinn, and Knoch and Marag completed a study in 2014 that evaluated the relation of post-discharge telephone calls by a nurse and the effect that they had on 30-day readmission rates. It was a retrospective observational study, and it determined that phone calls post-discharge helped to prevent readmissions, which is something that I included in my research. That statistical data was P equals 0.01. So PICO question, if you don't know, stands for patient, population, or problem. I stands for the intervention or issue. C is comparison intervention, like what you're going to compare your intervention to, and the outcome is the desired outcome. The population or problem that I chose was hospital readmission rates. The intervention is follow-up care by nurses that include both phone calls and home visits for patients, in addition to just the normal discharge printout instructions. And the comparison is normal discharge printout instructions only. And the desired outcome is decrease in hospital readmission rates. So this is, like, I had to come up with a theoretical research study that I would do in a hospital to find out farther what would help prevent readmission rates. So the theoretical framework that I used was the health promotion model. Noah J. Pender created the health promotion model to be a complementary counterpart to models of health protection. The model focuses on individual experiences and characteristics, behavior-specific cognitions and effect, and behavioral outcomes. The health promotion behavior is a desired outcome. Improved health, enhanced functional ability, and better quality of life are all results of practicing this health promotion behavior. Specialized care for patients will help to prevent readmission after discharge, especially using the health promotion model. So if you're providing specialized care to your patients, you're using the health promotion model. The design, setting, and sample. The design of the study will be an experimental quantitative research project. The groups will be a control and an experimental group, and the data will be collected from hospital admission records. The setting will be a large hospital in Louisville, Kentucky, and the sample will be all patients admitted to a hospital over a 6-month time span. The target sample size would be a minimum of 500 patients, so 250 in the control and 250 in the experimental. Data collection and analysis. So I'm going to use a self-efficiency scale created by a Self-Management Resource Center. I put a copy of it on the table if you want to look at that. The patients will rate themselves on self-confidence on a scale of 1 to 10, 1 being less confident and 10 being the most confident. The categories that the scale uses is exercise regularly, scale, get information about the disease, obtain help from the community, family, friends, community or communication with physicians, the management of the disease in general, if they have the ability to do chores, social and recreational activities, manage symptoms, manage shortness of breath, and control and manage depression. This tool is valid and reliable because it has been used many times and proven to work. The self-efficiency doesn't directly reflect readmission rates, but it reflects compliance, and compliance is like a big risk factor for readmission. It increases the chances if patients aren't compliant. In conclusion, hospital readmission rates will always be a problem. Research should be done to make it less of one. By conduction of the research study proposed, hospitals will learn multiple intervention follow-up care will lead to better compliance and self-care from patients, leading to better patient outcomes and satisfaction. But it's the nurse's duty to make sure patients are educated and they understand what is expected after discharge. And I know many times we're in a rush and it's hard to ensure that this is true. So providing phone calls and home visits as a routine follow-up care would be beneficial to patients, hospitals, and staff. It would improve the outcome for everybody. Do we have any questions?
No.
Okay, awesome. These are my references. And thank you guys for watching.